Niraimuri, followed by
Mama, Anusobia presenter.
sorry?
Anusobia will be presenting, ma'am.
Oh, sure. Sorry. Yeah. Okay. Yeah.
Okay.
Dr. Anu will be presenting, followed by a lecture, and I'm happy to take questions from you at the end of the lecture. So, shall we move over to Anu Shobia?
Yes, ma'am. We can start.
Thank you. Anu?
Hello, ma'am.
Do you want to? Yeah.
Ma'am, can you start the presentation, ma'am?
Yeah, sure. So, Anu, are you going to discuss your case?
Yes, ma'am.
Okay, carry on.
Anu, slides visible, no?
Slides
The
visible.
slides are visible. Yeah.
Yes, ma'am. Thank you. Yes.
Yeah, go for it, Anu.
Can you start the presentation, ma'am?
You want me to read out for you? Is that what you're asking?
Hello.
No, ma'am. She'll present the case.
No, ma'am, she will.
Yeah, okay. So, yeah, Anu, go for it.
Yes, ma'am. Mr. Shanti, 55-year-old female from Solavaram, who is a daily laborer by occupation, belonging to the socioeconomic class of 4, came with the chief complaints of bleeding per vagina for past 1 month. Next slide. History of presenting illness. The patient attained menopause 6 years back. The patient is apparently normal 1 month back, after which she had bleeding per vagina, which was gradual in onset, continuous and moderate in amount, 2 pads soaked fully per day, associated with clots and not associated with pain, ma'am.
Yep.
Next slide. And there was also a history of loss of weight and loss of appetite. No history of similar episodes in the past. No history of offensive discharge PV. No history of associated menopausal symptoms. No history of taking menopausal hormonal therapy. No history of usage of OCPs previously. No history of any previous investigations done and treatment undergone for postmenopausal bleeding. No history of any mass abdomen and mass descending per vagina. Rahul, next slide. Menstrual history. The patient attained menarche at 14 years. She had a regular cycle, 3 pads soaked fully per day, which is associated with clots and pain. Menopausal history. The patient attained menopause at 48 years gradually with no menopausal symptoms. Marital history. She married at 16 years and the duration of marriage is 38 years. No history of any infertility and no history of any induction of ovulation. Next slide. Past obstetric history. She had her first boy baby at 17 years. All the 3 trimesters were uneventful, which was a normal vaginal delivery, and the birth weight is 2.5 kilogram. No postpartum complications, and the baby cried immediately after birth and breastfed within half an hour, and he is exclusively breastfed for 7 months. Second boy baby at 19 years. All the 3 trimesters were uneventful, normal vaginal delivery. Birth weight is 2 kilogram. No postpartum complications. The baby cried immediately after birth, breastfed within half an hour, and exclusively breastfed for 6 months. And she had her third girl baby at 21 years. All the 3 trimesters were uneventful, normal vaginal delivery, and the birth weight is 2.5 kilogram. No postpartum complications. The baby cried immediately after birth, breastfed within half an hour, and she is exclusively breastfed for 6 months. Past medical and surgical history. No history of any diabetes, hypertension, thyroid dysfunction, asthma, epilepsy, and tuberculosis. No history of any previous surgeries and blood transfusions. Family history, there is no significant family history, ma'am. Personal history, the patient consumes non-vegetarian diet. She had normal bladder and bowel habits. No history of any drug abuse, smoking, and alcohol intake. Treatment history, there is no significant treatment history, ma'am. And on general examination, after obtaining consent from the patient is examined. The patient is conscious and oriented. She is moderately built and moderately nourished. There is a presence of pallor, ma'am. No icterus, clubbing, cyanosis, speedal edema, and significant generalized lymphadenopathy. And on examining the breast is normal. Thyroid examination is normal, and spine examination is normal, ma'am. Vitals, her pulse rate is 69 beats per minute. and her respiratory rate is 12 per minute. Blood pressure is 70 bar 110 mmHg. Temperature, she is febrile. Weight, the present weight is 61 kilogram. Weight checked 2 years back was 69 kilograms. So the weight loss is 8 kilograms, ma'am. Examination of respiratory system, normal vesicular breath sounds here, no added sounds. Examination of cardiovascular system, S1, S2 here normally, and there was no murmurs. Examination of CNS, no focal neurological deficit. Abdominal examination, on inspection, the abdomen is not distended. All quadrants moves equally with the respiration. Umbilicus in midline, no mass visible, no engorged veins, and no swellings in hernial orifices. And on palpation, the abdomen is not warm, not tender, soft, no palpable mass, and no organomegaly. And on percussion, there is no shifting dullness. And on auscultation, normal bowel sounds heard, ma'am. Inspection of external genitalia, labia majora and labia minora is normal. Pubic hair is sparse, and there was no local lesions and ulcers, ma'am. Speculum examination, bimanual pelvic examination, and perirectal examination was not done,
Why was it not done?
ma'am.
Why was there no examination?
Ma'am?
No, why was there no speculum examination?
Ma'am, patient நேரா பார்க்கல, ma'am.
Oh, yeah, sorry, I forgot. Yeah, okay, fine. Carry on.
Summary. Mrs. Shanti, a 54-year-old female, daily laborer by occupation, belonging to socioeconomic class 4, came with the complaints of bleeding per vaginum for past 1 month, who attained menopause 6 years back at her 48 years, and the bleeding was gradual and continuous, associated with the clots and not associated with pain, with a history of loss of weight of 8 kilograms and history of loss of appetite, and there was no significant treatment history and no significant findings on examination.
Yeah.
Diagnosis. So this is a case of postmenopausal bleeding for evaluation, ma'am.
Yeah.
Differential diagnosis can be either cervical polyp or cervical carcinoma or atrophic endometritis or endometrial carcinoma or ovarian causes like ovarian carcinoma. Next slide. Investigations, complete blood count, which include hemoglobin estimation, ESR should be done. Transvaginal ultrasonogram to rule out the endometrial thickness. Doppler study of endometrial growth, pap smear to see for any cervical pathology, endometrial aspiration biopsy, CT and MRI. If there is any tumor present, to see the extent, CT and MRI should be done. X-ray of chest to check for any lung metastasis, ma'am.
Okay.
That's it, ma'am. Thank you, ma'am.
Sure, that's a very comprehensive history. That's very thorough and comprehensive, and you've gone into the details of the trimester. Those are all the good things. I was looking for what was missing. The BMI was missing, I thought, but then you did say she was of moderate build and moderate stature. So that gives me a rough idea about her build. Blood pressure, do you mean 110/70 or 70/110? That's a bit odd. You mean 110/70?
110/70.
Yeah, that's what you mean. Yeah, I thought so. It must be a typo. Okay. See, it sounds like a fairly, you've given a fair summary of a patient whom you might have seen either virtually or in person. And based on what we have here, so we have a 54-year-old woman who clearly has stopped having a period. So she's established in menopause. Then she has had sudden onset of bleeding, and that bleeding was unprovoked, was it? It was not brought on by intercourse. She didn't fall or anything. Anusia, did the woman have a fracture or a fall?
No, ma'am. Nothing like that.
So no fall, no accident, no trauma, no sexual intercourse. Just
No.
spontaneous bleeding, yes?
Yes, ma'am.
Okay, and also there is a loss of weight of 8 kilograms with loss of appetite. So
Yes, ma'am.
any thoughts on what those two are indicating? What are they indicating to those two features?
Significant of any presence of carcinoma, ma'am.
Yeah, loss of appetite, loss of weight, or indicative of malignancy, usually of ovarian cancer.
Yes, ma'am.
Ovarian cancer presents as loss of appetite, loss of weight, change in bowel or bladder habits. That's a common presentation for ovarian cancer.
Yes, ma'am.
Because she is bleeding, we want primarily to blame the culprit. We assume it will be uterine. but more often than not in India, it can be cervical cancer presenting like that. It can be cancer of the ovary, estrogen secreting tumor, or it could be a ovarian cancer actually, or tuberculosis endometritis. That is more common there. I think for this lady, it is either first would be, we'll have to investigate the uterus. So she needs a transvaginal scan. Someone has to do a speculum examination, look at the cervix. Is there any obvious lesion on the cervix? Obvious lesion on the vulva, vagina. And then we need to do a transvaginal scan to assess the thickness of the endometrium and also look for any pelvic mass. If you find if the thickness is more than 4 millimeter, we take a biopsy either in the outpatient setting or in the inpatient setting. And the biopsy, if it shows whatever it shows, we act accordingly. If it is not cancer, then we reassure and discharge the patient. If we find cancer, then the treatment will be dependent on where the cancer is, what type of cancer it is. So shall we look at a little bit more about PMB in general, and then we'll come back to this lady?
Yes,
Sure.
Yes, ma'am.
So I think the sharing screen, the slides must go for me to share.
Yes, ma'am. 1 second, please.
Thank you.
You can share now.
Are you seeing the slides now?
Yes, ma'am.
Okay. So I'm going to talk about postmenopausal bleeding. Just to elaborate a bit more, understand the theory behind what it is, and then we can go into how we evaluate a diagnosis. So definition of menopause needs to be clear before we can talk about postmenopausal bleeding. A woman is considered to be menopausal if she has had more than 12 months of amenorrhea, that is lack of periods, and she is over the age of 40. That is when she is in menopause. So it is a retrospective diagnosis. In India, the average age seems to be 47 for most women to reach menopause, and the range varies obviously from 45 to 50 years of age. So you can see if the average age is 47, 1/3 of a woman's life is spent in menopause. And we have 60 million women in India over the age of 55. So the volume of patients, if you're going to be in general practice or obstetrics and gynecology, you will be seeing a good chunk of your patient population is going to be postmenopausal women with the menopausal problems or bleeding. So you need to be aware of this common condition and need to know how you go about evaluating this problem. So although we say more than 12 months of amenorrhea as a definition for menopause, any bleeding after 6 months of amenorrhea and ongoing periods at the age of 52 needs to be considered as postmenopausal bleeding and investigated as such. So you must now be beginning to wonder, what is the big deal about postmenopausal bleeding? Why are we making a fuss? We said 12 months definition, and then we are saying, no, investigate even at 6 months, investigate if a woman is bleeding at 52. So we don't seem to be happy with whatever the woman does, do we? Do you know why that is? The reason is because 10 to 15% of women presenting with postmenopausal bleeding have endometrial cancer. And 30 to 50% of these women with postmenopausal bleeding will have cancer of the genital tract in one sentence. And that cancer of the genital tract in India seems to be the leading cause is cervical cancer, which has an incidence of 1 to 1.8 per 100,000 women. That is a big number. And cervical cancer is a killer. Other cancers could be cancer of the vulva, vagina, or ovary. Ovary, it will be an estrogen secreting tumor for it to secrete enough estrogen to act on the endometrium and make it bleed. So that is your statistics. And the rest of the women with PMB, or 40% of the time, found to have hyperplasia. Hyperplasia is again a change in the lining of the womb, the endometrium. If it is simple hyperplasia, it is managed conservatively usually. However, if it shows atypia, which is a histopathological diagnosis, then the treatment is as that of cancer, because atypia harbors cancer in 75% of the time. Polyps, endometrial polyps are normally benign overgrowths, but up to 4% they may harbor cancer. So that can be an explanation. DUB, any changes to a woman's bleeding pattern needs investigation, which is what we meant by saying 6 months of amenorrhea, investigate. In UK and in the developed countries, what we do, women over the age of 40, any change to her bleeding pattern, we investigate and we want to rule out endometrial cancer. So that is it is taken very, very seriously. Any change in the bleeding pattern is taken seriously when the woman is over the age of 40. Other causes could be women on HRT. If the progesterone component is not enough, they could be a breakthrough bleeding. So that needs to be investigated and looked at, and we need to adjust the dose. And tamoxifen. Tamoxifen is a drug that you may be aware of, is given for breast cancer patient when there is estrogen receptor positivity. And these women, they take tamoxifen to prevent recurrence of a breast cancer. However, tamoxifen has an estrogenic effect on the uterus. So women on tamoxifen are 3 to 6 times at increased risk of endometrial cancer, and we classify them as high risk women. And atrophy is the other cause. So atrophy of the vulva, atrophy of the vagina, cervix, endometrium, any of these can present as PMV. That is the most benign of all. So these are your potential causes, which is what we were alluding to in Anu's Shobhya's presentation. So let us look at how we should develop a working plan to diagnose postmenopausal bleeding. So I would like you to have in your mind as a gynecological explanation and a non-gynecological explanation for bleeding. Gynecological explanation, I want you to look at the picture here. So vulva is not quite well demonstrated here. Just imagine where they say labia minus as the vulva. So vulva, what can be the cause? So we'll have to remember as trauma, foreign body, infection, inflammation, benign, neoplasm. These are the six principles you will have to apply for any area, and you cannot miss any diagnosis. So vulva, we will have what? Trauma, if she had a fall, we can ask that. An infection, inflammation, benign neoplasm, it will be obvious. You apply the same to all of these areas and there's your diagnosis. The extra bits you need to remember, cervix, it could be an ectropion, which is exposure of the endocervical epithelium onto the vaginal acidity, and therefore it is more friable and it bleeds. Uterus, we have said all of those. Adnexia, fallopian tube cancer, it's very rare. Ovary, it's a benign, it's usually an estrogen secreting tumor. So I hope that will give you an idea about your working plan. And non-gynecological causes, once we have checked the gynecological organs, what is in front of the uterus is the urological organs. So urethra, bladder, UTI, recurrent UTI. Urethral caruncle is nothing but a prolapse of the urological epithelium there. Papilloma or neoplasm. Back passage, back of the uterus is the rectum and anus. So you could have hemorrhoids, diverticulitis, inflammatory bowel disease, or again cancer presenting as bleeding. And we have said about hormones earlier on. The woman could be on hormone therapy, tamoxifen, or even anticoagulation for some other general problems. So these are the causes that you need to know, bear in mind when you're taking the history. And I was very impressed with Anu Shobhya's presentation. She had covered all of these in her presentation, so that's very good.
Thank you.
Moving on, so how do you work up to rule out a malignancy? So history, as she has taken, was excellent and was very good. And we have seen that she asked about diabetes, hypertension, BMI. She said no other history of note. So I assume she means no in particular relevance to no personal history of breast cancer, bowel cancer, and family history of bowel cancer. The reason we talk about bowel cancer in herself or in the family is because there's a condition called HNPCC Lynch syndrome. So she could be a carrier for that. So hence the importance of family history of breast cancer. The rest of it we have already covered. So you have a woman in front of you. I was also very impressed that you started your gynecological examination from the general examination. That is good. Most people think gynecological examination is straight PV. It is not. It is a woman is a woman, a holistic person. You look at them as a whole individual. So you look at the height, weight, BMI, check the blood pressure, check the urine. And then when you're looking at them, you look for anemia, jaundice, and look at the hair. Condition of the hair tells you if she's a hypothyroid. Eyes tell you if there is hyperthyroidism. So there are so many telltale signs when you look at the patient as an individual. And you must have heard this in your OPD. If you haven't made the diagnosis when a patient walked into your room, you've missed the boat already. So an examination, when you're going to examine the patient, it starts with inspection of the abdomen, palpation, percussion, as she quite rightly said, and a pelvic examination is look before you touch. So pelvic examination is inspection right from the mons pubis down to the anus. So that is your full pelvic examination inspection. And a palpation, you look for any obvious lumps, bumps, ulcers, you palpate those things. And you do a speculum examination. A speculum examination is either done with a Cusco speculum or a SIM speculum, whatever is available in your practice. This is to look at the cervix and to look at the vaginal walls. Vaginal walls, we want to look at front, back, two lateral walls. So there are 4 vaginal walls you are looking at, and you're looking at cervix in the middle. So by looking, what are you hoping to see? You're going to see if there's bleeding, if there's discharge, what is the color of the discharge, color of the blood, is there a smell to it? And is there signs of atrophy? So atrophy, it will appear as a thin skin of the vagina and thin cervix, where you can see the blood vessels through. It'll appear as dots. So that is what we're looking for: atrophic cervicitis, atrophic vaginitis. Is there prolapse? Is the uterus dropping down and rubbing on the skin, and is that why she's bleeding? Has she got a pessary that's holding the prolapse? So these are the things you will find by looking and touching and in those examinations. And after that, you do a bimanual examination. So 2 fingers in the vagina, right into the posterior fornix, and the left hand is on the patient's abdomen, and these 2 hands examine the uterus in between. And you want to assess the size, mobility, and what is it anteverted, retroverted, anteflexed, retroflexed, and you move on to the sides to find out the whether you can palpate the pelvic organs. The adnexa, which is the fallopian tube, and the ovary. Are they palpable? If so, what is the size? Is it mobile? What is the consistency? These are the questions you want answered. And a bedside test or urine dipstick, these are basics. You want to know whether there's an UTI or if there is frank hematuria in the blood. So that could be the explanation. So we need to do those basic things of urine dipstick. And your other blood lab test would be full blood count, blood sugar, again for diabetes, clotting, and the investigation tool of choice. First line investigation in the Western world is transvaginal scan for postmenopausal bleeding. And we go by the thickness of the endometrium. If the endometrial thickness is below 4 millimeters, we are fairly reassured that it is unlikely to be cancer of the uterus. An ultrasound scan will also tell us about the tubes and the ovaries, and if there are any masses sitting there, then we move with our imaging accordingly. So the sensitivity of 4 millimeter endometrial thickness in picking up endometrial cancer is 96%, and a false positive rate of 36%. Worldwide, 4 millimeters is accepted as the cutoff for further investigation for endometrial cancer. So once it's for more than 4 millimeters, we offer a tissue diagnosis, and the tissue diagnosis is sampling the endometrium. Sampling of the endometrium can be done in an outpatient setting or in an inpatient setting. It appears from reading your Shaw textbook that you guys follow in India that they seem to be favoring DNC still. But the sensitivity of a pipple biopsy, which is an outpatient procedure, fairly simple to do when you're examining the patient itself, is the sensitivity is 99.6% in diagnosing endometrial cancer. For the purposes of the exam, you guys follow what your textbooks say. They seem to be gearing towards DNC, and they're also talking about fractional curettage, which is separate sampling of the endocervix, the isthmus, and the uterus. So you scrape them and send them in 3 separate pots. So therefore, that will tell us if there is cancer and what is the stage of the disease. That seems to be the idea. And the gold standard is hysteroscopy. Hysteroscopy is passing a tiny telescope through the neck of the womb into the womb. So we have a good view of the womb and we take biopsies. We can take directed biopsies. Although we call it the gold standard, still the false negative rate is up to 3%. If we find cancer, we ask for further imaging in the form of CT, MRI, and occasionally, very occasionally, laparoscopy to assess the stage of the disease. Before talking about staging, I want to show you some pictures of how this is what. So the one I'm pointing, this is on transvaginal scan. This is the uterus myometrium, and the white line is the endometrium. You can see that it is thin, homogeneous, regular, and therefore, so let's call it a 3 or 4 millimeter endometrium. And I've given you some pictures to see how it looks like on hysteroscopy. So nice, smooth, panoramic view, and the cavity is regular. We call it a regular cavity. The endometrium is atrophic. Those dots on either end, or the ostia, the fallopian tube where it enters the uterus. There's another uterus, atrophic again, ostia clearly seen. These red blotches are probably from our instrumentation or signs of atrophy. Nothing to worry. There's nothing to sample. So we can reassure and discharge the patient. And here, if I called this one thin, obviously this is thick. So you can see it is quite thick. It's about 8 or 9 millimeter endometrium. And then she has a hysteroscopy, and you can clearly see in comparison to this picture here, how thick the endometrium is. So it is quite thick. Yeah, this is what we have seen here. And it's very easy to obtain biopsies in the outpatient setting. Take a biopsy, send it to the lab, and look for the results. That's what I would do. Nothing suspicious on looking at this one. And let me show you one more picture. So now look at this one. So this again gives you the impression that it is a thickened endometrium. But if you watch carefully, the endometrium is a thin line here, and then it expands. So which is what makes the sonographer think, is this a polyp? So then they have added some water in it, the saline. The saline distance the cavity, and therefore we can say this is actually a focal growth, so which is likely to be a polyp. And then she has a hysteroscopy, and hysteroscopy shows this within the cavity. You can see this growth. This looks quite innocent, and it's unlikely to be anything sinister. And the pathology in this woman turned out to be a benign endometrial polyp. The rest of the cavity you can see is quite thin and normal. Okay, and then let's look at this. So this is again on transvaginal scan. Look at the endometrium. We saw as a one fine thin line here. If you see, remember that picture, one fine thin line. And here we get as if it's cystically dilated, like almost like a polycystic ovary picture, but it's not ovary, it's an endometrium. And so this is very, very suspicious. This is screaming, I'm cancer. So this has to be taken seriously. And look at the other picture. It's grossly thickened and irregular pattern. So that is worrying. That is very, very worrying for cancer. After hysteroscopy, this is what we found. Copious, thick, proliferated epithelium, and it looks abnormal. This woman had G1 type 1 endometrial cancer. So this is just to give you some pictorial representation of what we are talking about. So moving on to the management, as I said earlier, we treat the cause depending on what we find. If we are fairly sure it is not cancer, the endometrial thickness we know, and we have taken biopsy when one was indicated. And we are 100% sure we have investigated the woman thoroughly, from the history, from examination, from ultrasound, from hysteroscopy, from biopsy, provided those were indicated and they're all normal. Then we look at treat the cause. So if it is atrophy of the vagina cervix, we give local estrogen in the form of a gel or a cream or a pessary that the woman applies in the vagina for no more than 3 months, and then she comes for a review for us to reassess the need for ongoing estrogen replacement. We tend not to prescribe estrogen replacement forever because of complications and side effects from it. Obviously, if you find ATP or cancer or somebody has recurrent PMB, despite all investigations being normal, we would still proceed with hysterectomy and BSO. The route of hysterectomy, whether we do it abdominal, whether we do it laparoscopic, open, or vaginal, depends on the descent of the uterus, the cervix, and the skill of the operator. Also, patient factors, patient's BMI, comorbidities, anesthetic risk, all that will decide which route that uterus is coming out. Very occasionally, we may have to involve other specialists, is what I mean by cross-speciality referral. It's very, very rare for us to involve others. If we don't find any of the problems ourselves, we do, I mean, in the female genital tract, we would do a cystoscopy and a proctoscopy to find out if there is a possible explanation. And if it is there, then we refer them to the urologist and the gastrointestinal colleagues. More often than not, we are able to treat this gynecological problem us as gynecologists and able to reassure and discharge women. And if hysterectomy is offered, that is usually curative for endometrial cancer. So very briefly, I'm going to touch upon endometrial cancer. The incidence of endometrial cancer, thankfully, in India is 5 to 7% of female genital cancers, as opposed to up to 25% in the Western world. And in India, the peak age of incidence happens to be 55 to 70, with 25% occurring in the perimenopausal age group and only 5% below the age of 45. There are two types of endometrial cancer, type 1 and type 2. Type 1 is estrogen dependent, type 2 is estrogen independent. So the risk factors I'm going to tell you now are for type 1 endometrial cancer. So this is any prolonged exposure of the womb to estrogen from any cause. So this would be your early menarche, late menopause, infertility, polycystic ovaries, ovarian disease, and ovulatory cycles. Women not having children, nulliparity, or all exposing the woman to regular exposure of estrogen, and this is one of the risk factors for type 1 endometrial cancer. BMI, high BMI is a risk factor. Diabetes, hypertension, hyperlipidemia are all risk factors. Anything that increases estrogen, and in diabetes, hypertension, obesity, hyperlipidemia, there is more peripheral conversion and aromatization of fat in the body, peripheral fat in the body to estrogen, which acts on the uterus and therefore increases the risk of endometrial cancer. And ovarian tumors, as I said before, this is usually an estrogen secreting tumor. Tamoxifen, we have said, familial lynch. And there's one light at the end of the tunnel. There is something protective about that women can take potentially. Combined oral contraceptive pill reduces the risk of endometrial cancer by up to 50%. And also, when you're starting HRT for any woman in your practice, when she's got a uterus, she must have progesterone. Otherwise, you're exposing that uterus to unopposed estrogen, and that risk of endometrial cancer from just exogenous estrogen is 4%, which can be reduced to 2% by adding 12 days of progesterone. How does endometrial cancer present? Like we have already seen, it can be as PMB, and don't forget the vaginal discharge. The woman tells you she's got an unusual discharge, smelly discharge, or colored discharge that ought to be taken seriously because it could be a presentation of endometrial cancer. In examination, you will find nothing to amass. And again, as I've said before, if the cervix looks normal and she's due for a smear, you will take a pap smear. If you see a lesion, a cancer sitting on the cervix, it is too late to be taking a smear. So you'll have to be biopsying that lesion that you are seeing, not taking a smear at that stage. It will be very wrong to take a smear on an obvious cervical cancer. And there is a small role for Doppler according to Shaw's textbook, but in clinical practice, it's not done. And once we know it is cancer from the tissue diagnosis, EB is nothing but endometrial biopsy. We go on to stage the disease. Staging the disease will be with the aid of CT or MRI. MRI is the gold standard in developed countries, but in India, I'm not entirely sure. Shaw's textbook seems to say CT and MRI. CT is cheaper, but doesn't give all the information. MRI gives all the information, but is expensive. So we'll have to also look at the cost in the services that we are working in. Cost is a huge factor in health. And a chest X-ray again for checking the lung metastasis. They say PET CT is the gold standard. It is only applicable when there are node involvement, and it shows hot and cold nodules. So we can decide what is the best type of treatment, whether it's surgery, chemotherapy, or radiotherapy. So for you to remember staging of the disease, I've put this picture here, and you can remember, you can apply this principle for any tumors you have to read about for any cancers anywhere in the body. Stage 1, cancer is confined to where it is originated from. Stage 2, it is just spread to the adjacent structures. Stage 3, local regional. Stage 4 is distant metastasis. Usually, stage 1, we can offer surgical management. It will be a hysterectomy. The staging I've said is surgical pathological staging. No matter how good an MRI or CT is, the final call is surgical pathological. So stage 1, we do hysterectomy, BSO. Omentectomy washings are usually done for type 2 cancers or for G2, G3 poorly differentiated cancers. That is done. And it could be open laparoscopic vaginal, as I said before. And stage 2, the endometrial cancer is now involving the cervix. So you treat it almost like a cervical cancer. So we do a Wertheim's hysterectomy, a modified Wertheim's, or radiotherapy. So the numbers given in brackets or that of the survival rate for each stage: 75% for stage 1 and 55% for stage 2, 5-year survival. From stage 3 onwards, it's inoperable. So it's given as a combination of chemoradiotherapy, and it's only 30% survival at 5 years. Palliative treatment for stage 4, mainly to improve quality of life. If they're bleeding, we give radiotherapy. Sometimes we offer women mild bleeding. We manage on tranexamic acid and norethistone. Any available preparation of progesterone is what is given. But if there is torrential bleeding and she's going to bleed to death, we don't want that. So we do give for heavy bleeding, torrential bleeding, they get radiotherapy. So that is your treatment in a summary. And I hope that has given you some idea about what PMB is and how to proceed with when you see a woman with PMB and what you need to be asking in your history. Time for questions, I think. Anybody has any questions? Did you hear anything? Hello?
Yes, ma'am.
Yes, ma'am.
Okay. Does anybody have any questions? Anybody want me to go through any of it?
Ma'am, I have opened the chat box, ma'am. People will type their doubts, ma'am. We'll
Oh,
try.
sure.
Yes,
Yeah, lovely. Thank you.
Ma'am,
Yeah.
from this overview, what will be the possibility of Anu's case, ma'am?
For Anu's case, I think it's we need to look at her cervix because she's socioeconomic class 4, and she's a high risk candidate for cervical cancer. Cervical cancer, we need to look at her cervix. One is cervical cancer because that is very common in India, and second is weight loss and appetite. Loss of appetite makes me think if she's got ovarian cancer. For her, those two will be the forerunners, followed by endometrial cancer.
All malignancies will have a
The ovarian cancer tend to present as loss of appetite and loss of weight.
okay.
And advanced cervical cancer will present with the bleeding, and they're almost cachectic. By the time cervical cancer starts losing weight and there is loss of appetite, loss of weight, it is very advanced. I think because there is no screening program in India, we are still having advanced cervical cancer in India.
Yes.
For her socioeconomic status, that is what I am having to think. Cervical cancer first, followed by ovarian cancer, then third would be endometrial cancer.
Okay, ma'am. Thank you, ma'am.
How can you examine those women if you're taking history virtually? I mean, how do you, is there a clinical placement at all, or you don't go to hospitals?
No, ma'am. We are in our home, ma'am.
Right. That would be difficult, but have you learned to examine a patient, a gynecological examination? Have you done that? Has anyone taught you?
Obstetric examination we learned, ma'am.
Yeah, okay. Yeah, obstetric examination. When you say obstetrics, you mean cervical assessment or bimanual?
Bimanual examination we have.
Good. That's fine. And speculum?
No, ma'am.
No, ma'am.
Okay.
We haven't done.
And because of the number of cases, there is no plan to start having patient contact, is it?
Yes, ma'am.
Yes,
Yes,
ma'am.
ma'am.
Okay. And so the exams will be in what pattern? OSCE?
They haven't decided yet, ma'am.
Oh, right.
Currently,
Okay.
theory classes are running, ma'am.
Okay. And yeah, okay, fine. Anushopia, have you got any questions about your case?
Hello.
Yeah.
Hello.
Yeah, we can hear you. Do you want the PowerPoint slides to be shared with you for you to have a copy?
Yes, ma'am.
If there are no further questions, shall we close the chat? Unless you want to ask any other gynecology related questions.
Ma'am, can you repeat the treatment part once, please?
Yeah, sure. For which one? For
Endometrial cancer.
Yeah, sure. Shall I share the slides with you again?
Ma'am, or you can just tell whatever.
Shall I tell you? Okay. So for stage 1 endometrial cancer, it is hysterectomy, bilateral salpingo-oophorectomy, omentectomy, and lymph node sampling and peritoneal washings. They are not, that is what your book seems to recommend, but here in UK we don't do omentectomy, lymph node sampling for most. No, that's not true. Stage 1, you remember like this. Stage 1, you do hysterectomy, BSO, omentectomy, and peritoneal washings, plus minus lymph node sampling, and 75% survival. 5-year survival rate is 75%. For stage 2, we can either do Wertheim's radical hysterectomy or give radiotherapy. And for stage 3, it is inoperable because there is loco-regional spread. So therefore, they get chemoradiotherapy. They get chemotherapy few cycles followed by radiotherapy. Radiotherapy will be in the form of pelvic beam radiotherapy or external beam radiotherapy. And stage 4 is palliative, which is symptomatic treatment depending on Usually the symptom is bleeding for in endometrial cancer, and the treatment is a hormones, which is progesterone, or in the form of radiotherapy. These are the palliative treatments that we use for endometrial cancer.
Thank you, ma'am. And also, is hypertension related to endometrial carcinoma, and why,
Yes.
if it is?
I think by hypertension, we know we can easily relate diabetes, obesity, and hyperlipidemia to more fat and fat aromatization. Hypertension, by constricting the blood supply, I think the systemic effect it has overall on a patient increases a risk of endometrial cancer. There's no direct correlation like we have with obesity and the endometrial cancer, but hypertension is a known risk factor for endometrial cancer by its systemic effect on the person as a whole.
Okay, ma'am. Thank you.
Thank you. You're welcome. Any other questions on PMB? So you will all know what to do when you have a PMB patient, because the history they will lead you in your long case discussion to a cancer. So I'm going to ask you, because you have no questions for me. I have a question for you. I'm going to give you 2 cases now, and you're going to all write an answer in the chat box, and I'm going to see now. Okay. So one second. So here I've got one case 1 for you, which is can you all see? I'm going to read out.
Yes, ma'am.
She's a 59-year-old lady who came in to your clinic with a history of spotting PV. There's no bleeding, she's spotting. And she has no risk factors. As said in Anushobia's history and in my presentation, she's not fat, she's not diabetic, she's not hypertension, no family history, no personal history. She has got no risk factors, okay? Then we go on to examine the patient. On examination, on speculum, you find a 2-centimeter infarcted endocervical polyp protruding from the endocervical canal. And obviously you see something, you remove it, and pathology comes back as benign endocervical polyp. What is your clinical impression? And tell me if you're happy with the management of this patient. What else do you need to do? I need you to answer 3 questions. What is the clinical diagnosis? Are you happy to discharge her? And whatever you say, is that the right decision? And justify why you're either discharging or keeping her with you. Justify your decision to me. So that is case study 1. So I'll give you 5 minutes. It's 12:19 in my clock. So whatever it is in your clock, it will be 19 minutes past. So 5 minutes from now, I want an answer. So 24 past the clock, past the hour, you have time to give me answers in the chat box. It's okay to make mistakes, but just guess. Just give me an answer. So basically, we are saying when we examined this woman, we saw an infarcted polyp, and that turns out to be benign endocervical polyp. So the question is, what do you think is the cause for her PMB? That is your clinical impression. And are you happy with your clinical decision? So what next is my question. My question is, what else, or what else do you want to do? That's my question. I'm getting some very good responses here. I'll wait for 1 more minute and then I'll talk to you. So it's 24 past the clock in my clock here. So I'm going to stop the sharing. 1 second. So therefore, thank you. It has been I've had some interesting responses. That's really, really good. The bottom line is, just because you have seen benign, you have seen something, that is not the only explanation for the bleeding. That is your bottom line. You've seen a benign polyp, you've seen a polyp, you've removed it, fine, but you still need to investigate her for PMB. You need to evaluate the womb with the transvaginal scan, know the thickness of the endometrium. And if that is not the practice there, while you're there, take a biopsy. Take a biopsy by all means. So just because you're seeing something, you've seen a lesion on the vulva, for example, in this case, it was a cervical polyp, doesn't mean that is the only explanation for the bleeding. You still need to evaluate for PMB with all the other things that we said, bearing in mind all the possibilities that we have been saying. So Aishwarya has given an answer. After removal of polyp, follow up with the transvaginal examination and pathological examination depending on risk factors. Yes, exactly. That is right, Aishwarya. As I said, we need to assume she has got PMB, and we have to do a complete investigation, not just get sidetracked by a polyp that we may see. That is the bottom line for you. Take home message for you from that case is, just because you have seen a simple polyp, you cannot say, okay, polyp removed, that's fine, we don't need to do a transvaginal scan or sample the biopsy. Cannot be said. You just still need to assess those things. Without an ultrasound scan, we cannot assess the endometrium, without which we cannot reassure anybody whether there is or there isn't endometrial cancer. It would be very, very unsafe to do. And with some of the comments about, there was one to say, do we do VIA? Yeah, that is when you're thinking about cervical cancer. That is a good observation, Anushobhya. But cervical cancer, we'll have to work her up for PMB. So whether you are going to keep a colposcopy examination of a cervix is not it's not the routine thing. And the loop also, only when there is suspicion of a cervical cancer, we will do with the loop. Somebody has asked about loop excision, or leap as you call it. It is not indicated in a normally looking cervix. You wouldn't be, if you see a lesion, yes, obviously you'll take a biopsy, and a biopsy could be in the form of a loop if you see cancer. But workup for PMB should not get sidetracked by something benign or just something that is visible straight as you go in, is the take-home message from that case. And one more case to wake you up a bit is going to be, tell me how you will manage this one. So she is a 52-year-old lady. she is bleeding while on continuous combined HRT after 1 year. She has no risk factors for endometrial cancer. We have taken a biopsy. Biopsy was negative. What do you think is the reason for her bleeding? So we have evaluated in this woman, we have evaluated her endometrium. We have done a transvaginal scan. We have taken a biopsy of the endometrium. We have examined the vulva, vagina, cervix. And what do you think is the reason for her PMB? What are you going to tell the patient? Why is she bleeding? She'll want to know. So if you can type in your answers, and you have 5 minutes from now. 52-year-old woman on HRT, bleeding after 1 year. So you need to know the types of HRT to answer this question. And I'm saying continuous combined HRT. Has anyone taught you about HRT already?
No, ma'am.
No, ma'am.
Okay, so I'll give you some of the answer. So continuous combined HRT is a type of HRT. The woman takes it without a break, and she is not supposed to have a period on it. She is not expected to have withdrawal bleed on it. And any HRT, they can bleed within the first 6 months. After 6 months, if they are bleeding on continuous combined HRT, we need to investigate to rule out endometrial cancer. So that is what that one line means. So this is a high risk presentation. She is bleeding after 1 year. So if she is bleeding after 1 year, we need to investigate for endometrial cancer. And the biopsy is negative. So see, okay, that's not fair on you if you don't know about HRT. So because in this case, the woman is on HRT and she started bleeding after 1 year of continuous combined preparation where she's not expected to bleed. We investigated her with a scan, we took a biopsy, both came back as negative, which means the progesterone component of the HRT is not sufficient enough for this lady. So we increased her progesterone component, and with the hope that that will settle the hormonal imbalance and will stop her bleeding. So 6 months later, she came back to us with the ongoing complaints of vaginal spotting while on HRT. So again, we investigated her. Endometrial biopsy was again negative. The tissue was only very minimal. And transvaginal scan was about 4.2 millimeters or something. And the biopsy was reassuring. Although minimal tissue, it was adequate for sampling. So we reassured the patient. So I'll give you the answer here. So again, we thought this preparation, this progesterone component is not enough for her, and we switched her from one brand to another type of estrogen and progesterone, and she settled well on it. But the take-home message for you is, just because a woman is bleeding is not always cancer. And if she's on HRT, if it is within 6 months of starting an HRT, we don't panic, we reassure, and we don't investigate them. If they bleed after 6 months is when we worry, and which is when we do a scan and take a biopsy. This is just to give you two different spectrums of postmenopausal bleeding that we see in day-to-day practice. Is that clear?
Yes, ma'am. Yes, ma'am.
Okay. Any other questions, students? To bleed, and as an adverse reaction for somebody to get PMB, I have not come across in clinical practice. It is only an overdose of warfarin or rivaroxaban or any anticoagulant they're on, and the INR is above the target range, is when they have bleeding from any orifice. And that is the presentation. I've not seen an adverse reaction to a drug as a PMB. Indication, oh, good question. Indication for HRT depends on which part of the world you ask that question. Indication is, there are quality of life issues. That is why HRT is taken. Over the age of natural menopause, which is 50, I mean, in India, they say 47. Natural age of menopause, if they're suffering from vasomotor symptoms such as hot flushes, night sweats, affecting their quality of life, and they're not able to perform, tiredness, loss of memory, they are started on HRT. But there is a medical role for HRT if there is menopause, in premature menopause below the age of 40. Why? Estrogen and progesterone. Estrogen primarily is protective against cardiovascular risk in the woman and protects against osteoporosis. And in addition to protecting women against from stroke and colon cancer. So if the natural source of estrogen is depleted for whatever reason before 40, we want to give the maximum estrogen protection and benefit to the woman. So therefore, we recommend women go on HRT up to the natural age of menopause, which will be 47 in India. But the vast majority of women in clinical practice we come across or taking HRT for quality of life issues, as I said before, the hot flushes, night sweats, tiredness, loss of memory, and dyspareunia. Those kind of reasons. It's mainly quality of life indication in the Western world. HRT is taken. People want to feel, look and feel better in themselves. So that is why HRT is taken, but it's not a medically indicated. It's very, very rarely we have to prescribe HRT for medical reasons. It's usually quality of life issues, which can be addressed by lifestyle modifications, reducing the spice in the diet, exercise, losing weight, having a generally healthy lifestyle, stopping smoking, stopping alcohol, modifying lifestyle will address most of the symptoms. There is a small role for antidepressants to be used in for menopausal symptoms, and natural herbs as well. They have a small role. It's mainly quality of life. And your Shaw's textbook that you're following is given quite a bit of detail about HRT. I was very, very impressed to see that. Why there will be urgency, frequency of maturation in menopausal women? Oh, good question, Nirmala. Excellent question. So somebody is listening. Very good. So the urgency, those questions, they are called urogenital symptoms. So the urogenital symptoms are seen in HR or seen in menopausal women because of estrogen deficiency. And the treatment for that is applying local estrogen in the form of a cream, a pessary, every night for 3 nights. And there is each each brand has got its own prescription rules. Every night for 4 weeks, every other night for 4 weeks, and once a week for 4 weeks is how we taper them. Or we apply gel ask women to apply every gel for gel every night for 4 weeks, and then we reassess. So it is due to urogenital atrophy and thinning of the urothelial epithelium, urogenital epithelium, and vaginal epithelium. Urogenital is the explanation for the frequency and urgency of maturation in menopausal women, Nirmala. So it is a urogenital syndrome, and it is treated as urogenital. Clinical diagnosis is urogenital atrophy, and the treatment is local HRT. When we say local, we mean local application, which is local to that is vagina. So that's the treatment. Thank you. Next question from Jayashree. Bleeding mainly due to estrogen progesterone imbalance or major estrogen component in HRT, ma'am? Okay. Now, Jayashree, mainly it is due to inadequate progesterone, or that particular component of progesterone not suiting the woman is the usual reason for withdrawal. Even when you look at combined oral contraceptive pill, women will bleed due to inadequate progesterone in that hormone that is given to them. So if once you adjust the progesterone component, you can give. Very rarely, both in contraception and in HRT, you're right, very rarely it can be due to estrogen being not adequate enough. So we do increase the dose of estrogen as well, but more often than not, the culprit is the progesterone. But estrogen is a possible explanation. Yes, indeed, you're right. Anything else? Let me know if you want me to go slower or repeat anything again. Let me know so I can change my presentation accordingly. And if there are no more questions, then thank you. Should we say goodbye?
Thanks,
ma'am.
ma'am.
Okay.
Thank you.
Yes, ma'am. Yes, ma'am.
Thank you, ma'am.
Thank you so much, ma'am.
Nirmala, special thanks to Nirmala and Anish Obgyn and this person appearing as KMC lecturer. I don't know your name.
Ma'am.
Rahul, ma'am.
Okay, thanks, Raghu.
Thank you, ma'am. Thank you.
Thank you, guys.
Thank you.
Thank you, ma'am.
And
Bye.
unless you give feedback, I wouldn't know how to tailor my presentation to your needs. So it's basically that I'm happy to support you in Ops and Gynae with relevance to your exam preparation. So if you tell me what you want, I'm happy to work to your needs. It's not. This is not a forum to display what I know. This is a forum to help you. So if you let me know, I'm happy to help you.
Sure, ma'am. I will convey them.
Thank you.
Thank you. Bye.
All right.
Bye.
Oh, sorry. Yeah, you want to say something?
No, ma'am. No, ma'am. Nothing.
Okay. Thank you.
Thank you, ma'am. Yes.
Thank you, ma'am.
Thank you, ma'am.